Hi, Dr. Windisch again from Sparks Pediatric and Adolescent Medicine. This time you don't have to look at me because my student here, student number 1, has volunteered to be on camera. So welcome to our video series for professionals, for students. If you'd like to schedule a rotation with us, please give us a call at 775-359-7111. We'll be happy to have you come on by just like this student is doing. Today we're going to talk about the differential diagnosis of what? The pink eye?
No, diaper rash.
Diaper rash. Of diaper rash, that's right, of diaper rash. Now, I get these calls in the office all the time. My baby has a diaper rash, what can I put on it? And my answer is always the same. I want to see you. And parents say, well, gee, it's just a simple diaper rash. Why do I have to come in and pay a copay for something stupid? And my answer is because it's not necessarily as simple as you think, which student number 1 is going to help us demonstrate. So what are some things that cause diaper rash? We'll start with the most common and most innocuous first.
Well, we have things like irritant contact dermatitis. Okay,
which is just that wet diaper rash dermatitis that babies get. What else?
Candidal dermatitis.
Okay, which we have lots of. And yeah, that one's simple and still reasonably innocuous, although not so comfortable. What else?
The secondary bacterial infections.
Okay, what else?
Miliaria.
Okay, what else?
Intertrigo.
Okay. Keep going.
We have granuloma gluteal infantum.
Okay, which is typically a complication of having put steroids over a fungus. A lot of times that's iatrogenic, but the parents can certainly cause it themselves from treating at home things that shouldn't have been treated.
Seborrheic dermatitis.
Seborrhea, okay, and its close cousin, atopic dermatitis.
Psoriasis.
Which is not common in infants, but absolutely can happen.
Impetigo.
Okay, definitely not rare in children. Okay.
Later.
Well, let's stay with impetigo for a second.
Okay.
Impetigo is caused by group A strep and staph. What is something else that we see that is strep driven?
Strep driven.
Yeah.
Pneumonia.
Well, in the diaper area.
In the diaper area?
Yeah.
For strep, you have the strep A,
vulvovaginitis and group A strep perianal dermatitis, or perianal cellulitis. Those two entities are anything but rare. I see it 4 or 5 times a year because I'm looking for it. Definitely not going to get better with steroids. Okay? And then what was the other one that you were hinting at just a second ago before I cut you off?
The next in differential? Yeah. Langerhans cell histiocytosis.
Okay, Langerhans cell histiocytosis, or histiocytosis X, previously, depending on what literature you're reading, referred to as Lederer's seaweed disease. Okay, this one is a bad actor. This one is neoplastic. This one will kill you. Can't diagnose it if you don't look. One that a lot of people don't see and that we didn't talk about yesterday, student 1, is something called cutaneous T-cell lymphoma. It's the same basic presentation as Langerhans cell histiocytosis, just more lethal.
Okay.
And easier to miss. So people say to me, doctor, how are we going to know that you're going to pick that up on the first go around? And the answer is I might not. But I'll pick it up on the second or third go around. The thing is this, I start reading the book the day you hand me the book to read. And I read the same book that anybody else reads, 1 page at a time. If I get the book given to me 3 weeks late because the parents were treating this at home, then I'm 3 weeks behind the 8 ball trying to figure out what's going on. If I start in the beginning reading the book on day 1 when the parents want to start treating, then 2 weeks into this things are not turning around. We know that we need to look at something else and perhaps biopsy this. Whereas if I wait for a month, by the time I figure out it needs to be biopsied because we finally started appropriate treatments, now we're 2 months into this. And especially because by the time the parents have got done putting steroids on things and occlusive dressings on things and making things worse, it really confuses things by the time the kid gets in to see me. So, the whole point of this discussion, it sounds simple. To a parent, it's simple. To me, it's not necessarily simple. And yeah, I might be able to walk in, take one look at it, and go, bingo, that's group A strep. But I don't know until I've seen it, and you can't diagnose a rash over the telephone. Do you have anything else on your differential?
I got a lot.
All right, let's hear what else you got.
Acrodermatitis
enteropathica. Okay. Also actually not rare, especially in preemies who are short gut. Okay, remember that zinc deficiency. Okay, what else?
Congenital syphilis.
Okay.
Scabies.
Okay. Now, scabies limited to just the diaper area would be unusual in an infant, but not unheard of. And scabies is the great imitator.
HIV.
Okay. And any of the HIV secondary infections from late stage AIDS. Okay.
And perianal pseudoverrucous papules.
Okay, which are more salmonly pink and they're papular, so they don't look quite the same as anything else, but they're still in the diaper area, so they're part of the differential diagnosis of, quote, diaper rash, end quote. What else?
I think that was about it.
Oh, there were others. Now some of the other things we talked about when we looked at some of the broader differentials yesterday, there are some other things that are coming to my mind that we talked about yesterday. We talked about tinea. We talked about molluscum.
Molluscum and Kawasaki disease.
And Kawasaki's disease. Now, the chances of this kid presenting with just diaper rash in Kawasaki's disease is pretty rare, since we typically think of Kawasaki's disease as having presented with 5 days of fever. And if you watch my Kawasaki's videos, I say it's sine qua non. That's not exactly true. There are very, very, very rare cases of Kawasaki's that present without fever. So diaper rash and coronary artery aneurysms. Ugh, good luck pinning that one down. But it can happen. You've got to keep it in the back of your mind. Okay, anything else?
Not that I'm recalling.
Okay, yeah, that's pretty complete. I mean, you could have Stevens-Johnson syndrome, but limited to the diaper area would be rare. Burns, chemical or thermal from child abuse or accidents, definitely not unheard of. And so keep that one in the back of your mind as well. If it looks like a burn, it might very well be a burn. So I hope this has been enlightening, eye-opening, and just give you something to think about. Because thinking outside of the box is important. If you think very linearly and only consider the common stuff, you're going to have a kid with Langerhans cell histiocytosis walk in, you will miss it, and they will die, and it will be all your fault. That does not mean you're biopsying every diaper rash. In fact, I have only sent one child for possible biopsy in my career to date, and that child was seen by dermatology, who tried one alternative plan while they were waiting for biopsy, and the patient responded to that alternative plan, giving them the diagnosis that they needed. So you're not doing that often, but you have got to think outside of the box, because although it seems innocuous and it seems like it's going to be simple, it's not necessarily simple. More importantly, I have had more than one patient who's gone to the urgent care or emergency room with group A strep perianal cellulitis or group A strep vulvovaginal cellulitis, and was given lotrazone, which is the last thing you want to be putting in a diaper area for any indication. And that just makes it worse because it suppresses the local immune response, allowing the strep to spread, and it also thins the skin and causes stria and scarring on the genitalia, which the patients just appreciate when they grow up. So think outside the box, and just remember, if it looks like a horse and it sounds like a horse, and or it looks like a duck and quacks like a duck, it probably is a duck. But sometimes it's not a duck, because sometimes when you hear hoofbeats, you're not in the Nevada desert, but rather you're on the plains of the Kalahari, and when that happens, it is a zebra. This is Dr. Windisch. If we can be of assistance, give us a call at area code 775-359-7111. We'll see you next time.